Thank you, Dr. Mee-Lee, for all of your insights and guidance and patience on really introducing some very complex issues. I just wanted to note that it's great to see the variety of backgrounds and jurisdictions that are on this webinar, participating on this webinar, and we look forward to any of your questions that you may want to submit. So I'm going to turn this now over to Dr. Mee-Lee. Thank you.
Thank you, Carolyn. Just a reminder that today's session is an hour and a half, so we are incorporating the questions and answers session all together. And of course, at any time during the presentation, don't feel you have to wait till the end of the session for questions. If something is said that you don't quite understand, please feel free to type that in, and Monica will interrupt me and let me know that we have some questions or comments or even disagreements. So we want this to be as much as we can via this format, a dialogue and interactive, so that we think together how to improve how we assess continued use and continued problems, and what we do in a criminal justice context with substance use for people who are in drug court or mental health court or other specialty courts. The title of this is called Relapse, Continued Use, and Continued Problems because it relates to the ASAM criteria dimension 5 by the same name, relapse, continued use, and continued problem potential. And I'm making the distinction there between continued use and continued problems to take into account mental health issues as well. There are people who may be in mental health court where the focus is not so much on continued use, but continued psychosis or anxiety, depression, suicidality. So in the ASAM criteria, we added continued problems to address mental health issues as well. So just to start off with some definitions, one way to see in this whole topic is not just to think straight away about relapse, but to think of slips, slides, and relapse. And this can be a useful clinical way of thinking about it because it has an impact for how you might view what's happening with a client at any particular time, and then also, of course, what you do about that. So from an addiction treatment point of view, a slip or a lapse could be seen as, you know, where somebody has a drink or a drug and it's a single incident that if you intervene early enough, or if they intervene with themselves early enough, that's all it is. So that they had a drink on their way to group, or they were on the weekend and they shot up something. And it could result in an ongoing relapse depending on how the client and actually the practitioner, the treatment provider, responds to it. If the client were to have a slip and then say, well, that's it, I've ruined it, I'm a failure, I might as well just keep using because I knew I couldn't do it, and that's here I go again, that slip could turn into a slide and into a full-blown relapse. On the other hand, if a client says, oops, I used, boy, this is really trickier than I thought, I've got to really bring this up at group and talk about this so this doesn't get worse. Let me really try to stop this in its track and nip this in its bud. Then that would not progress further. And also, if the provider says you used, oh, well, you relapsed, you're kicking you out or sanctioning you, then that person is never going to admit they had a slip again because they don't want to get into trouble. And that would be understandable in a drug court context that, well, then I'm not going to be honest about even one drink if I'm going to be slapped with a sanction and get into more trouble. So you can see very clearly that how we work with clients to view a slip or a slide or use is critical in terms of whether they will be honest with us, and then how we react to it and what our policies and procedures and how we deal with sanctions is critical as well in terms of whether people get the help they need or whether it goes underground. And then we actually precipitate a worsening condition by the fact that we did not have a chance to intervene early enough. Now, on the mental health side, you could see a lapse as a recurrence of a symptom of a disorder, so somebody gets suicidal or depressed again. It may be infrequent enough that it's not significantly interfering with their functioning. So it's really, again, how we intervene with that and nip it in the bud. Now, slide could be seen as slips and lapses that now start happening more frequently. Now it's not just one drink or one drug, but they've sort of been doing it a couple of times a day, or maybe every day, or maybe every other day. And it can provide an opportunity to prevent dropout from treatment and to stop it again in its tracks before a full relapse starts developing. So again, it's the same process. How does the client view the fact that, oh, it wasn't just one drink, but now I'm drinking every other day, or now I'm smoking something and this is not going well, I better raise this because I'm heading in the wrong direction, versus I'm not going to tell anybody because they're going to put me in residential or something, or increase my length of stay. And then it goes underground. Same with, what does the clinician do with it? Do they use it as a learning opportunity, or do they use it as, well, I'm going to increase your level of care, which the person may not even want or may not even need in terms of the assessment and the treatment plan? Because one of the things that happens is that when people use, we have an automatic knee-jerk reaction to increase the intensity of service or increase the level of care, and that may not be necessary. It depends on why the person used, and we'll get into how to assess this in a bit. But it depends on why the person used, what their skills are, what they're going to do about it, how does the treatment plan change, and then where can we deliver that treatment plan. It's not automatically up the intensity ladder just because somebody uses. That's doing treatment by a recipe book rather than by an assessment of what's needed. In mental health, lapsing can be, again, continuing symptoms that may be now they're feeling suicidal more frequently, or they're cutting themselves, or they're having more panic attacks or psychosis. And again, we want to stop a full-blown regression. We want to nip it in the bud as soon as possible and use it as a learning opportunity. Now, when we talk about continued use in addiction and continued problems in mental health, I'm using that in the sense that you can't actually have a relapse unless you've been in recovery and are committed to recovery. And I'll give you in a few minutes the ASAM definition of a relapse, which is really predicated on the fact that you can't have a relapse unless you first thought you had a problem, wanted to stop, did stop, got into recovery, from which you relapse. But if you just are using, you're just continuing to use. So you may have somebody who's very ambivalent about whether they even have a substance problem, and they're not at all committed to recovery, and they're there basically just to be in the program because they've been mandated. And then they continue to use. That would not be a relapse. That's just part of the fact that they have addiction which is not fully treated and for which they're not totally engaged in even trying not to use. So that would be the definition of continued use. Somebody who's not committed to recovery, hasn't ever had recovery, so you can't call it a relapse, and though it's still a problem if they continue to use, and again, a treatment planning problem, an assessment problem. In mental health, a person who's not committed to recovery in mental health may continue to have emotional, behavioral, cognitive issues as they work through their ambivalence about whether they have a problem. And then we have the word relapse, which, as I said, gets often used too broadly as any use. And it really isn't just any use. It's really an unfolding process in which the resumption of substance use is just the last step in a process that's been going on. So you'll often hear people talking about building up to a drink or a drug, or a person's disease getting active, meaning they now are not actually using, but they're starting to obsess and think about using. They keep walking by their old neighborhood. They start having cravings to use. They are beginning to isolate more and get away from recovery groups. So the relapse has already started, and then the final straw in that is they pick up a drink or a drug, but actually the process started much sooner than that. And the same again in mental health, that a person exhibits the signs and symptoms of their disease, but it has often happened that they're starting to get unstable before they actually cut themselves or take an overdose or get floridly psychotic. So relapse then as a process, not an event of using. And then the American Society of Addiction Medicine's definition, which is on page 427, if you have the ASAM Criteria book, says it's a process in which an individual who has established abstinence or sobriety experiences recurrence of signs and symptoms of active addiction, where they pursue the resumption of reward that they get from using drugs or the relief that they get from using substances and other addictive behaviors like gambling. When they are in relapse, they're often disengaged from recovery activities, or it can be the other way around. They start disengaging, and that is the beginning of a relapse process. Relapse can be triggered by exposure to rewarding substances, certain behaviors. So they're at a party, everybody's using, getting high, they look like they're having fun, that triggers somebody. Or they walk by their neighborhood and they see their drug dealer, or they see beer ads on TV, or they may have emotional stressors that trigger the solution to use substances as a way to deal with that. So depression, anxiety, they lost a job, they are losing a relationship, then that triggers use. So the event of using or acting out is really a latter part of the process. So as I said, when they pick up a drink or a drug, that's just the last part in a process that's been going on for a while, which is why when we see people building up to a drink or a drug, in other words, their attitude's changing, they're getting moody, they're getting isolated, they're starting to look like they're getting ready to use, even if they're not actively using, well, then that's when we need to be intervening and helping them before they actually use. But then if they actually use, we then still want to intervene sooner rather than later to stop it from really blowing up and getting way out of control. So use should be a signal for assessment and changing the treatment plan, not for kicking out or sanctioning, because then you push it underground where a person's not going to be honest if they're having cravings to use or even actual use. The other way to think about relapse is a broader definition that Alan Marlatt developed a while ago, where he said any violation of a self-imposed rule regarding a particular behavior is a relapse. So if somebody says, I really am not going to gamble again, or if I am, I'm just going to limit it to $20, and then they end up spending $100, that for them would be a relapse. Or somebody may say, I'm going to limit it to $1,000 gambling, and then they spend $10,000. So that would be, to them, violating a self-imposed rule. Or somebody says, I'm going to cut back on my eating and just have dessert every other day, and then they end up having it every day. That would be an example of, again, violating their self-imposed rule. In mental health, responding to lapses with old solutions likely to result in the return to pre-treatment status. So again, somebody in mental health gets depressed, they're used to taking overdoses, they then say, I'm not going to do that anymore, but then they end up doing it. That would be a relapse then. Or somebody else who says, when I get anxious, I scratch myself and cut myself, I'm not going to do that anymore, and then they end up cutting themselves again. So when we think about the definitions, it really has an impact not just in terms of how you define it, but how you respond to it, both at the client participant level and at the practitioner provider level. Because what we're really trying to do is to use the awareness of having a problem as a signal that things aren't going well. And that then needs to come to the treatment team as I'm heading towards some trouble. And ideally, you want them to say that before they actually pick up a drink or a drug. But if they do, you still want them to come as soon as they do that and not wait till it gets worse, which is bad for them, but also harder then to treat. And that puts an emphasis on then how are we going to really assess when somebody uses and turn that into a clinical issue needing a change in the treatment plan, not a willful misconduct issue needing to be sanctioned or punished. So in the ASAM criteria, we have constructs within dimension 5, which is relapse, continued use, continued problem potential. We have constructs that really help to assess what went wrong when somebody uses, and then how are we going to take care of that? How would we need to change the treatment plan? Because it isn't a matter of doing a generic relapse prevention plan, one size fits all. It's really saying for this particular participant, what are their particular vulnerabilities around continued use, or if they've had a period of absence sobriety, what are their particular vulnerabilities that could flare up and then create a full-blown relapse. And so it isn't good enough to say this person needs residential treatment because they're at high relapse potential, because then you say, well, what do you mean by high relapse potential? Well, you can't just say, well, their potential for relapse is very high, because then you have to say, well, what about the potential for relapse is going to make them more vulnerable? Well, I don't know. We're just going to do a relapse prevention plan. Well, yes, but what are you going to put in that relapse prevention plan that's specific to this particular individual's vulnerabilities? Because not everybody who uses has the same triggers, the same vulnerabilities, the same temperament, the same kinds of pressures that they succumb to and use. So substance use is just a very overall sign and symptom. Well, actually, the sign is that they use, the substance use. The symptom is I feel like using. I'm having cravings to use. I feel myself building up to a drink or a drug. That's the symptom, and then the sign is they actually use. So when people have a sign that they use, they get a positive drug screen, that just means they got a positive drug screen. That doesn't tell you what to do about it for this particular person. So let's go over the constructs within Dimension 5 to help you think through. Now, if you're a treatment provider, you should be thinking about these very specifically. If you're a court team personnel, it's not necessary for you to have a detailed, workable knowledge about assessing this, because that's outside your scope of practice. That's what you have to leave to the treatment provider to do a thorough assessment and then a new treatment plan with the person, and then to report that back to you about the participant is in good faith working on this. They are very now aware of what their vulnerabilities are, and this is what they're committing to do in treatment to prevent this happening again, if at all possible. But as you know, flare-ups and relapses and continued use doesn't just happen once or twice. This can flare up like any chronic disease, where people's blood pressure can go up, or their blood sugar, or an asthma attack, or whatever. So the treatment provider needs to be much more savvy about these constructs and to be really clear on what is going on, to make sure that they do a careful assessment of what went wrong and then change the treatment plan. Now, let's go through then what a treatment provider should be assessing in detail and what a court personnel person should just be aware of in terms of the level of sophistication that you hope the treatment provider has in identifying what's gone wrong with the positive drug screen. Monica, I'm noticing that one of the participants has lost the sound. I want to make sure my sound is coming through okay, is it?
Your sound is coming through okay. Occasionally people do lose sound, and if the sound does not return, all you have to do is click on the phone icon, which is in the participants panel at the right, to join the teleconference, and hopefully that should fix any problems anyone's having.
Okay, good. All right, so the first thing is to look at how long has this person had a problem with substance use, or if it's a mental health client, mental health issues, because the chronicity of the problem can contribute to how likely is it that this person's going to have another flare-up or have any flare-up, especially if their treatment or change response has been very meager and limited. For example, if you have a person who's only been able to get 3 months of sobriety or an abstinence, that doesn't bode well in terms of what strength, skills, and resources they have to resist temptations to use. On the other hand, if you have a person who's had a problem for 20 years, but they had a good 10-year period when they were sober and doing well, that tells you something about the level of skills, strengths, and resources that they have, which even if they're now using again, they can call up, and you want to harness those in a treatment plan. Even if somebody's just had a year or 6 months, that the response of that should be, well, 6 months, that's great. How did you do that? How did you change for 6 months? And what were the mechanisms? Were you active in AA at that time? Were you able to really have good peer refusal skills? Did you know how to deal with pain and negative affects without drinking and drugging? So you wanted to understand why and how they were able to have whatever length of time they didn't use. In fact, even if somebody says, I didn't use for a week, the response clinically should be, that's great that you didn't use for a week. How did you do that? Oh, well, I wasn't hanging around that friend during that week, or I wasn't actually in my neighborhood where drugs are readily available during that week. I was on vacation away from it all or something. Because then you start identifying what works for that particular person, even in a week of abstinence. But better still, if they've had a problem for a long time and they've had periods when they've done well, then that says, here's a person who can go back to some of those methods and do well. On the other hand, if somebody's just had a short time at a problem and they haven't developed much experience about what to do with cravings to use, then they're going to be more vulnerable because they haven't had any treatment or anything to move back to help them to cope. Then another thing to assess if somebody uses is their pharmacologic responsivity, meaning are they using for the positive reinforcement that drinking and drugging gives them. It gives them pleasure, it gives them euphoria, it gives them a good high. If you have a person who's still at that phase of use, then even if you put them into withdrawal management and get them free of any drugs that they've been using, there's going to be an allure to go back to that use because it's still, you know, they have euphoric recall about how great it was. Versus somebody who has negative reinforcement, meaning that they are only using to stave off withdrawal discomfort, or they're frightened that if they stop, they'll not be able to cope with stresses. They don't get a very good high anymore. I used to get high, and it used to last several hours or even a day, but now I'm lucky if I get half an hour. But I don't want to stop because I don't want to go into withdrawal. That person, if you're able to get them into some withdrawal management and get them free of the drug, they may not have such a strong as impulse to go back to it because it's not doing so well. So So when a person uses, you want to try to get a sense of were they using to get high because it still does something for them, or were they using because they were starting to go into withdrawal? If somebody was using because they started to go into withdrawal and got scared about it, then that might mean doing some interventions around helping them to have comfortable detoxification, or what we now call withdrawal management. And that would be a different intervention from somebody who used because they said, I just want to get high again. And I was feeling a bit bored and I thought I'd get high. Well, that person's going to need help not so much with withdrawal management. They're going to need help with how could you replace the need for some excitement and for some distraction, or dealing with wanting to have some pleasure in ways that would be the non-addictive. How can we help you get a new high that is not going to get you into trouble? Another reason somebody may use is because of external stimuli. They are very reactive to acute cues. They see a beer ad on TV, they have an impulse to use. They walk by their old neighborhood, they see where their drug dealers hung out, they get triggered and want to go and check that out. They may have an angry situation, and as a response to anger or disappointment, they get triggered to using. If that was one of the numbers of reasons somebody used, then that would take a different kind of intervention. How do we help you to delay the need to react by using if you're suddenly feeling depressed? Or how could you avoid going by your neighborhood so you're not triggered by seeing the old neighborhood and seeing people? So a very different, quotes, relapse prevention plan depending on what the issue is, or a very different treatment plan modification if somebody actually uses, not just sanctioning somebody for the use, but assessing what went wrong and how do we change the treatment plan. What is their reactivity to chronic stress? Some people use because they are homeless, they don't have any money, they're worried about even getting some food. So a lot of negative stresses, and to drown all that out, they use. But it's not just negative, it could be positive. Somebody could actually be having positive stress, meaning things are going well for them. They now have not used for several weeks or months. They start thinking, well, maybe it's not as bad a problem as I thought. They start not going to meetings and getting the support they need. So in actual fact, the things are going better, but that's a setup for actually using, because now they start not taking seriously their recovery plan. It could be that a person uses because of their cognitive and behavioral strengths and weaknesses, like what is their locus of control. A locus of control is whether somebody is internally oriented or externally oriented, meaning an externally oriented locus of control is somebody who perhaps ends up drinking in a bar, and their external locus of control tends to blame other people, places, and things. Oh, well, you know, it was my friend. They made me come into the bar, or I think it's just bad luck, or I think there's an eclipse of the moon, and that sort of affects my craving to use. I don't know how I ended up in the bar. I just suddenly was. That's an external locus of control, much more vulnerable to having problems with relapse or continued use or continued problems, because they don't take any personal account for what they did to set themselves up. So an internal locus of control, a person does that. A person with an internal locus of control may say, well, what was I thinking, not taking my own transportation to a party where everybody was using so that I could escape if I got uncomfortable? What was I thinking even going to a party where everybody's using? I mean, how did I think that I could go to a party and everybody's intoxicated or drugging and I'm just going to stand by and watch? What was I thinking going to a bar and thinking I could just have Dr. Pepper while everybody's drinking and rowdy, and I was just going to play darts in the bar and have Dr. Pepper. What was I thinking? That's internal locus of control. And if somebody has an internal locus of control, that bodes well or better for them being able to take care of relapse or continued use problems. And then there's self-efficacy, where it's really looking at what is this person's optimism or confidence that they can actually make some changes. If a person doesn't think that they can actually change, even if they want to change and not use and be abstinent, but if they have a low self-efficacy, they're not even going to put the effort into doing it, because what's the use of my trying to stop? I'm just a failure. I'll never make it. A lot of people we work with have very low self-efficacy. They've been told explicitly or implicitly, you're a loser, you're a no-hoper, you're a chronic recidivist, you're somebody who never puts the money where their mouth is, you don't walk the talk, you don't really try hard enough. So they've often been given that message from parents or other adults, and then they internalize that and say, I'm a loser, I'm the black sheep, I'll never make it. Why even bother trying? I'll probably just fail like I've done it before. So assessing a person's internal or external locus control, assessing their optimism and confidence to make changes if they thought that they wanted to make a change, has a big impact on whether they're likely to continue to use or how they're going to cope with an incident where they used and how they're going to change their treatment plan. We want to know other cognitive behavioral measures like their coping skills. To what degree can they deal with feelings of sadness without using? To what degree can they have good peer refusal skills? Do they know how to look at cognitive things and say, wait a second, let me think this drink through. What if I use, this is going to happen, this is going to happen. Well, no way I want that to happen. I got to quit even thinking about that. I can just have one drink. So what are their coping skills in thinking things through? What are their peer refusal skills? If they don't have a clue about how to say no to friends who are offering them drugs, then they're going to have more trouble with flare-ups and relapse. What is their impulsivity? This is a big thing to assess as well, because I remember seeing a young NYU student who was 20. She had been suspended from classes because of not showing up. She was suspended because she was found to have used substances, and you know, she was using IV heroin. I said, you must have started using very early on to be up to IV heroin and in such bad trouble with school and so forth. And she said, well, no, I didn't actually use until I got to college, because I grew up in a very strict family and we didn't use. But she was a risk taker and thrill seeker. So when she got to college, somebody said, hey, try this. She'd try it. Other people would say, no way, I'm using needles. I'm not going to touch that. So it has an impact as to what your level of impulsivity is. And remember, we're assessing this not just to assess it and then give them a generic relapse prevention plan. We're assessing this so that we can make the plan specific to their needs. So somebody with impulsivity and risk-taking, thrill-seeking type temperament might need to be with the bungee jumping, skydiving recovery group, not the needlepoint, read the big book recovery group. That wouldn't fit what they're needing to help them deal with their particular temperament and personality. And then, are they passive or passive aggressive? Because one of the reasons people use is because they are very passive or passive aggressive. Are you going to go to AA meetings? Well, absolutely. Well, what meetings are you going to go to? Well, I'm going to get me one of those meeting books. Well, how are you going to get there? Since you've lost your license, you can't drive. Well, I'm going to get a ride. Well, do you have any names and numbers to get a ride from? Well, I'm going to get me some of those. See, what is that person's risk of flare-ups or use versus somebody who says, here's my meeting book, on Monday I'm catching the bus, Tuesday I can walk to a meeting, Wednesday somebody's picking me up, Thursday I'm riding my bicycle. You know, that person's risk of a flare-up is less than somebody who's passive or passive-aggressive. Now, of course, people don't just have one of these areas. They may have all of them, or a combination of them, or at any particular episode of use, it may have been stimulated by a different aspect from another one. Somebody may ended up using because of coping skills around peer refusal skills, or it might have been that they had some trigger when they walked by the neighborhood, or it might have been that they ended up having some depression and they tried to cope with that by using. And it may be a combination of those. So that's why it's too treatment by the recipe book to just say somebody used, so now you're sanctioned. If somebody's in treatment for addiction treatment, we have to see use as a clinical issue that needs to be treated and assessed, and where the treatment plan needs to be changed so that we can address the particular issues in any of these constructs that a person may have that explains why they use. So there are all kinds of crises, there are all kinds of things that can happen both in addiction and mental health. And these crises then are not just to be ignored, they are what makes it important to assess and see how we're going to help this person sort this through. So I'm going to now go through a policy and a procedure that would speak to how we should address when people use from a clinical perspective, and so that treatment providers then can convey to the drug court team, we know that this is not a good outcome. It's not because the person has willful misconduct and is just trying to use. Don't sanction them because we're changing the treatment plan, and this is how we're going to change the treatment plan. Now, of course, if somebody is using just because they think, well, I've been mandated to treatment, I don't really have a problem. While I'm here at this treatment program, I'm going to get some stuff and use and have a little party, then you can talk about sanctioning because they're not actually doing treatment. They're just doing time and thinking that they can while away their time, make it a bit more palatable by actually using something. No, that person is needing to be sanctioned because they're not doing treatment. But if you have somebody who is doing treatment, then what we want to do is help them. So a policy and procedure would be as soon as somebody uses, you would want them to be honest with you, and you have then see this as a crisis that it is, and have a face-to-face appointment, or if that's not possible straight away, at least a telephone appointment, to approach them with an attitude of acceptance, listening for what's their point of view, how did this happen, what triggered you, you know, really running through eventually an assessment of those constructs to find out for this particular person, what was their vulnerability that day when they picked up. So you're doing that rather than to lecture them or just enforce program rules. Okay, you use, here's what's going to happen to you. You're going to be sent away to a more intense level of care, or you have to come back tomorrow when you're stable, or whatever the rules are. And we certainly don't want to just dismiss their perspective, because why and what happened when they used is going to shape the treatment plan. The first thing you have to do is make sure they're safe, so you run through the 6 dimensions to assess any immediate needs. If they started using again, did they start using to the point of they're going to have withdrawal seizures or withdrawal potential? Or was it just a slip where they were just acutely intoxicated for a brief time and are not now intoxicated, and we can really be with them and help them to recognize what went wrong. And then you want to make sure that there's no biomedical conditions. Say somebody gets depressed or suicidal, did they take an overdose? Did they cut themselves and need sutures? If they drank or drugged, did they drink to the level that it flared up some co-occurring pain problem or some co-occurring diabetes or hypertension problem? Dimension 3, did their use make them feel demoralized, make them feel suicidal? if it was a mental health flare-up, what exactly happened, why did they get more psychotic, and so forth. Readiness to change, we want to check out immediately. If they used, are they now throwing in the towel and giving up, feeling like it's not even worth trying? Or did they use because they started to get ambivalent again? Well, I haven't used for 3 weeks. I think I may not have such a problem. I could just try 1 glass of wine or something. So you want to know if there's any immediate needs, especially if they feel like, well, this is hopeless, I might as well give up straight away. We have to sort of inspire them and keep them engaged. An immediate need might be that they used or relapsed, and now they're in such volatility, they just can't really pull it together to not continue to use. We're going to have to give them more intensive services for that. Or was it a Dimension 6 issue that is now creating imminent danger? Is there somebody who's abusing them that we can't send them home tonight because they could be at danger? Is it somebody who is in a toxic environment that we have to help them deal with? So we want to run through any immediate needs. You take care of them if there are immediate needs. If not, you go back through the situation. If you have somebody use, please come to group. And if they've not so intoxicated or not so suicidal or so unstable, you know, they're able to get something out of the group, because if you've just had a beer or 2 or shut up something or smoke, that doesn't render you a cognitive vegetable. You can still speak to people. Now, if you're so intoxicated or so psychotic or so suicidal that in the immediate need profile you realize, well, they're really unstable, we have to take care of that, well, then, of course, you don't bring them to group or you don't have an individual session with them. But if they just use, they had a slip, or they've been using every day even for the past week, but they're not now intoxicated to the level of slurred speech, they're able to participate, then you want them to come to group, and the goal is to discuss what went wrong, with the next step being, based on that, to modify my treatment plan and work on any new or updated problems. Now, of course, if you find somebody not interested in modifying the treatment plan, well, then that may tell you that they're just sitting there doing time, not doing treatment, and you can reassess, are you really here to do treatment, or do you think you can just sit here and sort of party away because you're not really interested, but you have to be here, sort of mentality. You then determine if you do have a person who wants to modify their treatment plan, do they need same level of care or a more intense level of care or not, and what do they, it's not automatically up the ladder or down the ladder. And then if the person recognizes that they have a problem, I know if I said I got another positive drug screen, I'd stay away from those friends, but I still want to do it, well, then they can choose no further treatment and be discharged because they're not interested in treatment. But if they're invested in treatment, treatment continues, and we document that crisis and don't sanction them because now they're going to change their treatment plan. Monica, do we have a question or comment?
We do. And it's directly related to what you're talking about now. So the individual says, what are some of your suggestions for changes we can make to treatment plans for individuals who continue to use despite being in intensive treatment for a long period of time?
Yeah, so if they continue to use, but they're willing to change their treatment plan each time in a positive direction, you keep going. So it shouldn't be like count by the numbers, 3 strikes and you're out. If somebody continues to use and they're still invested in treatment and doing the best they can, that just tells you the severity of their illness and what we have to do to work with them. So, for example, say they continue to use because on dimension 3 they have a co-occurring trauma issue, and then they had a flashback and they ended up using as a way to cope with that. But then they say, okay, I'm willing to add a trauma therapist to my treatment, and they're doing some work on that, and things go along okay, but then they have another flare-up, and that was because on dimension 6, they lost their job, or they had a relationship that said, we're done. and that got them to flare up. And then they say, okay, I'm going to really need some help. Maybe I need to go to more meetings to get more support during this stressful time, and that's moving the treatment plan in a positive direction. You would keep going. And then things go along okay, and then they use again, either because on dimension 3 another trauma thing came up in their trauma therapy, or on dimension 2 they also have co-occurring chronic pain, and they had that fairly well established and okay, but then they got severe back pain again, and they had an impulse to use some drugs to cope with that. And then they realize, wow, I've got to start going to physical therapy more, or trying to do some of those more mindfulness exercises. So when you say, what can we do in terms of changing the treatment plan for somebody who keeps using, my next question is, why do they keep using? Is it because of some of the problems in any of those dimensions, or have you done a careful assessment in all of these constructs to make sure you're addressing the fact that they, are still very focused on getting pleasure from use, or that they don't know how to cope with acute triggers to use, or don't have good peer refusal skills, or they didn't get that sponsor or that ride because of their passivity. The only time you would start talking about discharge or putting a person in a sanction if after they get a positive drug screen, they're not willing to look at what went wrong and what do I have to do to change my treatment plan. Then you can say, well, you're not really in treatment. You're not really changing your treatment based on your progress. Well, I'm here in groups, aren't I? Well, that's not doing treatment. That's just showing up. We want to know, what are you going to do differently in your treatment plan based on the fact that this is not going well. And the fact that it's not going well doesn't necessarily mean it's willful misconduct. You have to look at what are the reasons the person used and what are we going to do about it, and to change it in a positive direction. Please come back at me if that didn't help, because we want to make sure this makes sense and it comes back to an individualized assessment and treatment plan. Now, so we just talked about a policy of a way to deal with that, and that would be what the treatment provider would look at. And if you had a person who recognizes the problems, understands the need to change, I know I should have stayed away from their friends, I know I should go to more meetings, I don't want to, then the treatment provider would recommend to the court a sanction, not for the fact of the positive drug screen, but for the fact that the person's not invested in treatment. Now, if they get reinvested and are willing to change their treatment plan, then treatment continues. If the person doesn't get reinvested and say, well, I'd rather just do my time, it's all this hassle of treatment, well, then they can do their time and not be in drug court. So the point is that use is, again, to circle back to do a multidimensional assessment to change the treatment plan. And we went over this in the first webinar, look at all of these areas to see what do we have to do differently in the treatment plan. And for somebody who continues to use, you might have to consider medication. And so I just put in here a quick review of medications that might need to take place. And you'll see that I call this medication in addiction treatment. So if you're married to the term MAT, medication-assisted treatment, I'm encouraging you to start thinking of it not as medication-assisted treatment, but medication in addiction treatment. Why? Because medication-assisted treatment isn't a philosophy. It's just really having medications in your toolkit that some people may or may not need for dealing with relapse. And so one of the things that if somebody has an alcohol use problem, we're not going to go in detail, there are medications that can help with that. Naltrexone, disulfiram or antabuse, or acamprosate or Camprel. And so medication may be part of the treatment plan for somebody who's relapsing. I'm just noticing a question here. What are some therapeutic adjustment options other than moving someone into a more intensive level of care, like doing a workbook or journaling? Yes, let me respond to that, because I think I just went over what some of the therapeutic adjustments would be, but it's dependent on the assessment of what the problem is. And you're right, definitely don't just automatically increase the intensity of the treatment in terms of level of care. A good example of this was I had a client when I was working in Hawaii who was a medical student, actually, who was hooked on methamphetamine. And he was in our intensive outpatient program doing very well, actually quite excited about the fact that he wasn't using and that he was feeling much better about himself and about the gains he'd made just in a couple of weeks, to the point that he then wanted to visit with his friends, and did on the weekend visit with his friends who were still actively using, and his intent was to try to get them to join him in recovery. Well, of course, he got overwhelmed with the environment there with his friends and showed up on Monday, and the counselor said, we have to transfer him to residential because he relapsed over the weekend. And I said, well, what happened? He said, well, he went to visit friends trying to get them to join him in recovery and got overwhelmed and used with them. Well, I said, is he willing not to visit those friends and to go to more meetings and do service there instead of trying to make 12-step calls on people too early in his recovery? He said, well, yes, he's willing to do that. Well, I said, well, why are you sending him to residential? Well, he's failed outpatient. Well, no, he just shouldn't have gone to see friends. And now that we know what was his trigger and he's willing to change his treatment plan, then there's no need to change the level of care. So it could be that if somebody's doing interactive journaling, that you give them the journal on relapse issues, or you focus on what were the circumstances that caused the problem, and they can do that. So very, very much a change in the treatment plan, not necessarily a change in level of care. Now, if somebody says, I'm doing my best in intensive outpatient, but I'm getting cravings all day, every day. If I know that I've got any friends around and using, I have a hard time not going to the party with them. I am really having a lot of struggle with getting to meetings because as soon as I walk by my neighborhood, I just get a trigger to use. I've got to get away from this. Well, then you might put them in some level of residential treatment to give them a break from that while they build up some more other skills. And that would be an increase in level of care. Or if not residential, somebody's intensive outpatient, they say, if I could come here every day and really get some support, I think I could really get a handle on some of these cravings to use and get some more education and support. You might move that person from intensive outpatient to a day treatment program. But all of that is dependent on what the treatment plan is, around what the problem is, around what are we going to do, not based on some automatic up the ladder or down the ladder. You may have a person who has opioid use disorder, and they may need, for their relapse or continued use problems, to be on methadone or buprenorphine or naltrexone. And naltrexone, extended release, injectable naltrexone is Vivitrol, if you know it by that name. And again, we're not going over details on this, but just a reminder that medication-assisted treatment is not a philosophy. It's medication in addiction treatment. Some people need medication, some people don't. Some people need medication for hypertension treatment, some people don't. Some people need medication for diabetes treatment, some people don't. Some people need medication for depression, some people don't. Some people for addiction treatment need medication, some people don't. It shouldn't be a philosophy, it should be just one of the tools in the toolkit. And then we don't talk much about nicotine addiction, but nicotine addiction can be a trigger as well. So for a person who has a nicotine addiction, there are medications, as you know, patches, gums, inhaler lozenges, and bupropion, or Chantix, or the generic name varenicline. So please consider medications in the treatment plan for somebody who isn't doing well. But again, it shouldn't be everybody gets medication or everybody doesn't get medication. It should depend on what this particular person needs. And then we do that in a continuum of care, whether that be outpatient treatment, intensive outpatient, and so forth. So a reminder, though, that when we're thinking about continued use, or if a person uses substances, it may have something to do with dimension 4, their readiness to change. And so we're not going to go over in detail this because we've gone over it before, but you want to know at what stage of change are they at as regards abstinence and sobriety. Now, you remember that everybody who's talking to you and is in treatment is at action for something. But they may be just in action for getting out of drug court, or they may be just at action for getting their kids back, or just at action for getting the judge or the probation officer off their back, or just at action for getting housing or a job, or getting on SSI or disability. They may not be at action for sobriety and recovery and wellness. And so therefore, their substance use is not so much a relapse issue, a dimension 5 issue, but actually motivational and engagement issue. They don't actually even think they have much of a problem. I can stop anytime I want, but then they don't really have the skills to do that, and they may not even be all that interested in stopping. So you get people who are in treatment programs and they think, well, I'm mandated to be here, but I'll have some fun while I'm here. So they sneak getting something and then end up using. Well, that wasn't a relapse issue or even continued use in the sense that they were trying not to use but didn't have the skills. It was just a willful dimension 4 issue. I'm not interested in sobriety. I'll have some fun while I'm mandated to be here. That's a person who you would recommend a sanction for because they are actually not interested in treatment. They're just doing their time. All right, Monica, do we have some questions, comments, disagreements?
We do have some questions. The first question is, for clients continuing to use and not following through with suggestions made by treatment, would it be appropriate for the court to require the client to make changes, for example, move to a new home, don't associate with certain peers, etc., or else be discharged?
Well, this comes back to the issue that when people are in treatment, you want the treatment to be a collaborative process with the person. So say the person says, well, I don't necessarily want to move to a different place, or I don't necessarily want to give up those friends. Well, you have a right to do whatever you want to do, but then what are we going to tell the court about your positive drug screen and how you're going to change your treatment plan if you're not willing to take those suggestions, because those are my best top suggestions because you said this happened when you were still associating with those friends or when you're in that neighborhood. If not changing your whole place of where you live and changing all your friends, what are you willing to do in a positive direction so that we are looking at progress, not perfection? Because remember, you as a clinician may have the very best plan, but just because it looks the very best plan to you, that doesn't necessarily mean that's what's going to work for the person. Now, it might seem obvious to us what needs to be done, but you have to take into account the person's stage of change. If they're not ready to make that from their heart, and then you just mandate it from the court and then threaten them with do it or else, yeah, they're going to agree to do it, but that doesn't mean they're going to actually do it. They're going to look like they're doing it. So you see this in child protectors and family court where somebody's living with somebody who may have domestic violence or who's not a good partner, and then the court mandates get rid of that person, and they're not emotionally yet ready to work that through. They'll agree to do it, and then the person sneaks in at, 2 a.m. and sneaks out at 5 a.m. or something. The focus gets more on how do we look like I'm complying than on actually changing. So when a person's in treatment and you get a person who says, well, I don't want to do that, you don't just say, okay, you don't want to do it, well, then just stay in the program. You say, well, if not that, and let me explain why I think that would be the best plan, because as I talk to you and assess, that's what happened that you used. If not doing that plan, what's your plan that you would be willing to do that's in a positive direction? It has to be in a positive direction doing something. You can't just say, oh, I'll try harder without that being specific. What are you willing to do? And then work with that. But the reason I think that may not work is because you still hang out with those friends. But I'm willing to give it a try if you're willing to get rid of one of those friends, if not all of them. And I'm not just going to tell the court to mandate you to get rid of all the friends, because you're not ready to do that yet. And then you won't really do it, or you'll make it look like you're doing it, and you won't really be doing it. And that's just compliance. We want you to adhere to a treatment plan you're going to put some effort into. And if it works, great. But if it doesn't work, well, then we'll have to modify it further. So the answer to that, sorry if that was long, was no, don't just say, well, that's what I think you should do it or else, and I'll get the court to mandate it, because that puts the emphasis on compliance to mandates than on personal responsibility for changing the treatment plan and holding them accountable to the outcome.
Great. Thank you, Dr. Mee-Lee. And we have another question. The individual says, if the participant verbally states that they are willing to change and I have identified what their triggers are, but they continue to have the same infraction, would it be appropriate at that time to increase the level of care?
Well, listen to the language. You see, if they have the same infraction, this isn't about breaking rules. This is about, have they internalized that those are my triggers? So yes, you do an assessment and you say, it really looks like you have a problem with using because a part of you is, I'm going back here to just remind you, as an external locus of control, where you tend to, just say suddenly I showed up in the bar, and you don't look at what part of it I'm doing. And so if they get that they need to work on their external locus of control, and you work out something that they can do. So for you, how about before you just go to a party, you ask a friend, does it make sense for me to go to this party if I'm trying not to use, instead of just going to the party and then blaming everybody else for using around you. And then on top of your external locus of control, you tend to have a hard time saying no in terms of coping skills to friends who offer you drugs. Or also, when you get depressed, you have a hard time not using. So which of these three things do you want to get started on, or can we work on all three? Working out how to say no to friends, working out how to deal with negative affects without using, and then what you could do to deal with your external locus of control. You have to explain this at a level of their, education and so forth. And then you work out a treatment plan. So now you say, well, I think I know what the problem is, and I've even told the client, and we've even worked out a treatment plan to work on that, but there they go, they got another positive drug screen. Well, see, again, you have to assess, well, was that too much? Did we try to get them work on an external locus of control and poor peer refusal skills and dealing with negative affect? Was it too much for the person, or did they not understand what they were doing? Or they were trying the hardest on that, but you can't change overnight or in a week or two if these are lifelong patterns. So again, the answer is no. You don't just say, well, I've identified what your problem is, I told you what to do. You're still getting positive drug screens, so now it's willful misconduct, and you need to be sanctioned. Or now you're obviously failed at outpatient, so we're going to put you in the residential, when it might not have been a failure. It's just that it was too much all at once, or they need more practice with that. And if they need more practice with that, and that can be safely done in outpatient, no need to put them into a more intensive level. So again, you only put them into more intensive levels, either more frequency in outpatient, like IOP to day treatment, or from day treatment into residential, if the assessed problems are such that they need treatment that requires that kind of intensity of service. We're going to review that again in a minute when we go through the decisional flow. And I'm sorry to sound like a broken record, but it comes back to what is the problem, how do you change the treatment plan, and where can you deliver that? It isn't, again, we told you what the problem is, you still didn't get it, so now we're going to increase the level of care, because that may not be necessary. It just needs to change the treatment plan in the level they're already at. And again, when I give these responses, if it still doesn't make sense, feel free to come back and interrupt me and say, well, what about this? All right, so I'm going to keep going with some of the material here because we talked about medications, maybe part of the treatment plan. It may be that you need to change the level of care, but not necessarily. It depends on what the change in the treatment plan is. And it may be that the problem of the substance use is a stage of change issue around dimension 4, not just a relapse issue around dimension 5. So you remember we said if somebody's still ambivalent about whether they have a problem, they need a discovery dropout prevention plan, not a recovery relapse prevention plan. Now I want to talk a little bit about proximal and distal goals, because this comes up in terms of, again, some of the traditional ways of dealing with this is that abstinence is a distal goal for participants with addiction, or in the old days of DSM-4, substance dependence, where we said if you have substance dependence and addiction, you need treatment. So don't make abstinence a proximal goal where you mandate that from court, because they need treatment. They're not going to be able to, if they've crossed the line of addiction, achieve abstinence perfectly from day one just because you mandate it. So make abstinence a distal goal, and then if they use early on, well, then we have to change the treatment. What was often said is a proximal goal should be abstinence if they have substance abuse, meaning that this assumes that their substance use is voluntary. Now, that's not even quite right in terms of DSM-4, where there was substance abuse and substance dependence. But I don't want to get too technical here, but substance abuse was a diagnosis in the DSM-4. There's now no longer substance abuse or substance dependence, just substance use disorders, mild, moderate, and severe. And I'll tell you what my recommendations are. If you have somebody who doesn't actually have addiction, we should approach that differently from somebody who does have addiction. So I would agree that abstinence is a distal goal for people who have addiction, but I will also disagree with that in a second and say abstinence might be a proximal goal for somebody with addiction if they are interested and ready for abstinence. In other words, you might work totally on that, and then if they still get a positive drug screen, still not sanction them, you still do treatment. We'll get to that, jumping ahead a bit. Traditionally, we've often said people with complex needs, dual diagnosis, trauma, other kinds of problems, the term regimen compliance is a proximal goal, and a better way to say that, I would say, would be treatment adherence. But the traditional focus is if you have a person with more complex needs, don't sanction them for using, so make sure that the proximal goal is making sure they adhere to the treatment. And I would agree with that. For actually anybody. Traditionally, we've often said that if you have a person who uses in early phases of the drug court, well, then you increase the treatment for the person with addiction, but you punish with sanctions once they are engaged in treatment and have some sustained sobriety. What that sort of assumes is that a person who's had some treatment and sobriety, now if they use, it's willful misconduct and they should be punished. And I would disagree with that, because a person who has addiction, even if they've got some established sobriety, can have flare-ups. I'll do one more on this slide and then we'll take the question or comment. Traditionally, we said for non-addictive participants, you want to actually sanction them early on if they use, because you don't want to reward them getting away with things of using. But we'll talk about how we should approach people who are not addicted and what we should be doing with substance use with them. Let's see, I thought we had a question or comment, Monica. Did that disappear?
Just a comment thanking you. So.
Oh, okay. All right. Very good. Thank you. So what do I recommend in terms of this proximal and distal issue? Well, proximal and distal goals have often been predicated on the idea that this is a behavior problem and that we need to use reward and punishment, sanctions and incentives to modify behavior. I would propose that addiction is more complex than that. It's really a brain disease that has biopsychosocial, spiritual manifestations, and that if a participant has addiction, treatment is needed. And if they don't have addiction, then you don't put them into drug court treatment. We do the same kinds of things we do with people who speed or who get a DUI, that if they get a DUI, they have escalating legal sanctions. If you get a speeding fine, you can, and I can unfortunately speak from personal experience, you cannot have points on your record if you take a driver's education course, right? But if you get another speeding fine, they're not going to just say, well, you know, just have a driver's education. Maybe you have more of a problem than you realize. If it's same with a DUI, if you get one DUI, you can get education and risk advice. But if you get a second one and a third one, it starts escalating in terms of both the legal consequences and your need for treatment. So firstly, if somebody's in a drug court and they don't have addiction, I would say they don't need to be sent off to a residential treatment program or intensive outpatient. They may need education, risk advice, and recognition of what their legal consequences would be if they continue to use. If somebody does have addiction and we say the reason they're offending is because they've lost control, then they need treatment. And then, is abstinence a proximal or a distal goal? Well, in the treatment sense, it might be a proximal or distal goal. Let me explain that. If somebody comes into treatment and they have addiction and they say, because of my arrest, I realize I've hit my bottom and I don't want to get into more trouble with the law. And so thank you, court and judge, for giving me a chance at treatment so that I don't just do time in prison and I can divert away from that. And I'm so grateful for that I hit my bottom through this and that I've been given the chance through drug court to get help, then my proximal goal is abstinence in treatment. And it's not for the judge to decide to mandate abstinence. That's for the treatment provider to work out. So that's why we say the judge mandates assessment and treatment adherence. You may get another person who goes into drug court who says, I want to do my time in treatment, not because I think I have addiction and want recovery, but because I'll do whatever it takes to graduate from drug court. For that person, abstinence might be a distal goal, and in treatment, you might be doing a discovery dropout prevention plan. Now, this is a little radical, and I don't want to blow you away, but say you had a person who doesn't think they have a problem, and they can just cut back. A motivational plan, if not mandated abstinence from the drug court, might be, well, let's see if you can just cut back. Now, I don't want to go into this because this raises all sorts of fears, but I can tell you from a clinical point of view, to engage that person in a discovery dropout prevention plan, it might be that abstinence isn't the immediate goal. Abstinence would be the distal goal, and that you'd be doing motivational strategies to get that person to that. Or if that's too scary to you, you might say you have to be abstinent, but you think you can do that and still hang around with friends, or you think you can do that without going to AA. I don't think you can, but let's try that out while you're in treatment, where you have a chance to do the research without this blowing up, because I don't want you saying you're going to AA when you're not, and then everybody thinks you are, and then it blows up later. So the issue of distal or proximal goals in terms of abstinence should be an assessment treatment issue based on stage of change, not based on court orders. And then you use escalating sanctions in initial or later phases of treatment for lack of good faith and effort. You don't use sanctions for signs and symptoms of addictions, because even though a person has been in treatment for 6 months even, and even though they might have had negative drug screens for 5 months, and then they get a positive drug screen, that doesn't mean, okay, now we sanction you because you should have known better. No, the disease of addiction is such that somebody can have flare-ups at any time. And it may not have anything to do with, well, I'm going to use and screw them, and for which they should be sanctioned. Now, of course, if somebody has been in treatment and had 5 months of abstinence, and then they say, well, I feel like using, I'm going to use, and then they get a positive drug screen, and they use not because they were trying not to use and they have addiction compulsion, but they just said, I'm going to get high, well, then you can sanction them, because in that assessment, it wasn't that they were trying not to use. They were just saying, I don't even think I have a problem now. I think I can get away with using. Then you can talk about sanctioning. On the other hand, somebody who's trying not to use ends up using, that in the assessment you see that this is part of a relapse issue, then they shouldn't be sanctioned for it. Now, I think why this gets complicated is that people say, well, they're just going to say, my disease made me do it. And so that's why I use, don't sanction me. Well, it's not as simple as just the client saying, my disease made me do it. It should be an assessment. You can assess whether somebody is in good faith doing treatment. Like, well, how many meetings have you gone to in the past week? Well, I've dropped away. I haven't been going. Well, how come you've got sign-offs that you attended? Well, I just got them to sign it, and then I went out the back and went away. Well, no wonder you use. You haven't been taking care of things. What are you going to do about that? Well, I don't like it anyway, and I don't want to go, and I'm just going. I'm just sort of doing time. Well, then you might sanction them because they're not actually making a good faith effort. But if somebody has been going to meetings and they've been trying to get a sponsor and they're working as hard as they can, and then they end up using, you might say, well, how can we help you to get a sponsor? Or how can we help you find a different kind of mutual help group if this is not working for you? So it really is a discussion with the client and an assessment with the treatment team to decide, is this willful misconduct for which they should be sanctioned, or is this addiction? It shouldn't just be automatically positive drug screens later in treatment get sanctioned, positive drug screens early in treatment don't get sanctioned, they get treatment. You could have a person who early in treatment gets a positive drug screen and you would sanction them because they're not doing good faith effort in treatment. I hope that's not too confusing. So to try to pull this together, you've seen this before in our first webinar, what does the client want? Is this a person who is saying now, because of my offense and the realization of where my life's led, I want recovery? Or are they just saying, I want to get through drug court? Then we want to make sure we assess all of their 6 dimensions to see if there's some immediate needs. So this is, again, if somebody uses, so they're already in treatment and they used, and we say, well, you used. Are you thinking now that you don't have a problem, you can use anytime you want? Are you thinking now you don't care about drug court and screw it, I'm just going to use? Are you really invested in treatment, or are you just sort of going through the motions? So if somebody uses, we would want to re-engage them. Are you in treatment or not? Or are you just saying, well, I have to be here, so I'm gonna use? And then if they did use, as I said, you want to make sure that they're safe. So go through the 6 dimensions and make sure that their substance use hasn't caused some other dangerous thing that we have to take care of, like withdrawal management or they're intoxicated and it made their co-occurring trauma worse, and we have to take care of that. If there are no immediate needs, you then go back through the 6 dimensions and to say, have we got the diagnosis right? If we have the diagnosis right, let's go through the dimensions and work out what the severity and level of function is, what went wrong, which dimension flared up. Was it a dimension 5 issue? And we go through those constructs. Was it a dimension 4 issue? Was it a combination of that? Was it a dimension 6 issue? They started hanging out with the wrong friends, or they got into an argument with a partner, and then the first thing they could think of was to use. And then to focus and change the treatment plan with them. What are we going to do then with the fact that you got upset with your partner and the first thing you thought of was to use? How can we focus on that, dealing with negative affects by using substances? How can we change your treatment plan? Can we change that treatment plan here in the level of care you're in? Or are we now needing a bigger dose of services where the only safe place to do that is to increase your level of care? And then we'll track and see how that's going again. Hopefully you never use again, but don't be surprised if it should happen. If it does, please tell us sooner rather than later so that we can then readjust your treatment plan to get the best outcome. So this is again an issue of looking at any flare-ups as an opportunity for reassessment. And then there's a bibliography, if you get the slides, and some other resources, of course, with the website that are listed there. Well, we've gone over a lot, and this issue of proximal distal goals is something we have to keep having conversations about. But I want to really stress that substance use is not just a black and white issue. It's much more the signal that things aren't going well and that we need to reassess and do another treatment plan. Comment or question, Monica?
Looks like we just got a question. Would you recommend to refer all referred clients coming into the program to get a mental health assessment as well?
Well, when we're reviewing the 6 dimensions, there should be enough history information to decide, does this look like somebody who may have on dimension 3 a co-occurring condition for which we need a more specific mental health evaluation. But I wouldn't automatically say everybody has to have a mental health evaluation, because especially if somebody's actively drinking and drugging still, they can look like they have a mental disorder. And if you send them especially to a psychiatrist or a clinician who doesn't have good addiction training, unfortunately they will almost automatically get a psychiatric diagnosis and a prescription like bipolar disorder or something. And it may be that their mood swings have nothing to do with bipolar disorder, but just addiction. But on the other hand, if you, in taking a history, have somebody who had a mental health problem that predated an addiction problem, or has had significant sobriety, like a year or 2 or 6 months, and during that time they still had significant mental health problems, even though they weren't using, then that might be the signal that we better perhaps dig a little deeper and get a mental health evaluation and see if this is a person who has a co-occurring disorder. Now, that reminds me that tomorrow, if you're able to be on, we have a challenging case, which is an excellent case around co-occurring issues. It's a drug court challenging case where we'll be looking at, is the drug court the appropriate place for this person to be at, because they were not able to achieve significant abstinence, so are not progressing well through the drug court phases. And that will be a great case to discuss. That's going to be tomorrow from 1 to 2 Eastern. And then a reminder that our next webinar session around a topic will be on Wednesday, April 27 from 11 to 12:30 Eastern on how do we get there from here. We've talked about a lot of different attitude changes and policies and procedures. where would we want to start? What might be a game plan about how to get to this approach where we marry the importance of public safety and the priorities of the court with the importance of treatment and treatment teams. And then our last challenging case will be on Tuesday, May 3 from 2 to 3 Eastern. And if you have another a challenging case, we'd love to have you write that in for May 3 and send that to Monica, because the cases are really where it comes to life here to apply these principles in the real world. And we have a great case for tomorrow if you can join us to illustrate some of these points. So the quick answer to that was no, not everybody should get a mental health evaluation, but everybody should have mental health screening and enough information to point you to whether that might be something that might be needed. All right, we're getting close to the end. Yeah.
Yep, it looks like we don't have any other questions at this time.
Okay, so I thank you all again for those of you who could join us. If in the meantime you do have other questions and comments, even though we won't be having another session just on that, I welcome any emails or comments or disagreements or things to help you to keep building this information into your daily work. So thank you for attending, and again, these will be published on YouTube and on the American University website, correct, Monica?
Thank you, Dr. Thank you, Dr. Mee-Lee. This is fascinating. So look forward to the session tomorrow. Thanks.
Thank you, everybody. Bye-bye.